Thanks very much for the intro. It's a pleasure to be able to come here and speak to you about something which truly is a passion of mine. And really what I want to do is share my thoughts about this disease with you. Someone recently described osteoarthritis as a complex, illogical, changing disease associated with aging. And that really sums up part of the dilemma that we have in trying to deal with this disease. As vets, we also see this very early in an animal's life because of a lot of the genetic orthopedic problems which will produce joint damage early and allow arthritis to develop at very early stages in life. And the other paradox, if you like, about osteoarthritis is, depending on your point of view, everything works or nothing works when you try to manage this disease. And I'll try to expand on that as we go through things today. So my plan is to first of all tell you why I became interested in the disease, try to give you some reasons why I think a lot of treatments fail, try to persuade you that a multimodal approach is a better way to try and deal with the problem, and lastly, show you how I personally tried to come to terms with this problem and use a system which makes multimodal treatment practical. So coming back to interest, it's very unusual for an orthopedic surgeon to be interested in arthritis because arthritis is often regarded as almost a failure. Most orthopedic surgeons are only interested in the case until it disappears from the clinic. But I became interested in arthritis as a disease for a number of reasons. Firstly, because I was seeing a lot of cases, and what I could see didn't tie up with what I was investigating in terms of radiographs, etc. We've all seen these animals who come into the clinic. They look perfectly normal until we take an X-ray, and we find they've got radiographic osteoarthritis. So that's one of the first paradoxes, was there wasn't really a match-up between the clinical and the investigative. And that was further compounded by some of the work what I was doing. I was fascinated at that time with inflammatory joint disease, and a big confession, I was actually trained as a neurologist as well and switched to orthopedics, which is a bit unusual as well. But I was fascinated in inflammatory joint disease. And when I was doing surgery in joints, I used to always sample synovial fluid, and I used to always take a synovial biopsy and look at these. And again, I found there wasn't really a good match between the pathology that I could see inside the joint, the pathology that I could see inside the membrane, and the clinical signs. I also then, when I showed an interest in arthritis, I was seeing a lot of referred cases, and it fascinated me how these cases came in with so many treatments that the owner could hardly carry the tablets that these dogs were on. So they were on huge numbers of treatments, but they were still coming to me because the problem wasn't solved. And again, as part of that, I was interested in the number of treatments which really had no evidence, which people were using to try and deal with this disease. And also the fact that this was very similar to the situation in humans. So it was a disease that perhaps wasn't managed as well as people thought. So I do think that it is an underestimated disease. It's very common. 1 in 5 dogs in your clinic will have this problem. It is more common in older animals, but we can see it in very young animals. It is probably the most common source of chronic pain in our pet population, which is something we don't often consider. And although we think about the great killers like cancer and heart disease, if we take a step back and think about when or why dogs are euthanized, having osteoarthritis comes very high up the list. So it is a very common reason for euthanasia. When we look at the owner's perspective and our interaction with the owners, very much like the human situation, owners are often very frustrated and disappointed in our attempts to try and give their pets a normal life. And I think this is one of the reasons that they often start using a lot of treatments which really are arthritis drugs as a label without any real evidence that they work in arthritis. And it's not just the owners. I'm afraid as veterinary surgeons, our frustration sometimes leads us to go down this path as well. So if I asked you to describe the typical osteoarthritic joint, you would probably tell me that osteoarthritis as a disease is a progressive, degenerative condition with no cure. And that's correct. And you would tell me that the main sign is pain, and it's a very, very debilitating disease, which is correct. You would also, if you were talking to the owner with one of these dogs, say, what we're going to do is, this is a lifelong disease, and your animal probably will require treatment for the whole of its life. And we're probably going to use some things that we don't know whether they work or not, because they're arthritis drugs. And we're going to change the diet, reduce the diet, and the dog's not going to be able to exercise properly. And when you think about it, once you neuter a dog, the only two things it lives for are to eat and to exercise. So we're saying all these things are going to be removed, and we're going to charge you for that. So you're going to pay us to make your dog's life miserable. So it's not an easy sell. It's not easy to convince people to really tackle this complex disease head on. So what is wrong with management? Well, one of the big things is that we fail to have a good understanding of this disease. We call it osteoarthritis as if it's a single entity. It's a multitude of different disease problems, depending on the joint that's involved, depending on the stage of the pathology, depending on the individual's perception to the pain that's being produced in the joint. We also have a very poor idea as a group, and it's not just us, it's our medical counterparts as well, about chronic pain and chronic disease. Two things that we don't like. We like things that get better when we treat them. We don't like lifelong disease. And as part of that, with osteoarthritis, we don't really make a provision to maintain our good treatment for the life of the animal. And we don't pass that on to the owners. And this diagram I used to kind of summarize what we're good at in osteoarthritis and what we're not good at in osteoarthritis. Arthritis is a little bit like a journey where once things start, the joint is damaged, and we know that we can't cure arthritis. The joint's probably not going to heal. So we get this progression to a stage where the joint ceases to function. And during this journey here, we get punctuated clinical events where the animal becomes obvious to us that it's got a problem. And we're very good at reversing these events. In fact, the honest truth is most of these events reverse themselves within 7 to 10 days. So sometimes the treatments we use, we think, well, that's fantastic, that works. Actually, if you didn't use that treatment, the dog would get better anyway. So that is not really the big challenge. The big challenge is this line here, because what we should be trying to do is extend the functional use of that joint for longer before it reaches this stage where we can't really treat it. So that's one of our big failings with the disease. So why do treatments fail? So I'm just going to give you some of my opinions and some different perspectives where I think that because of the way we look at things, we actually are going to fail with our management. So what exactly are we trying to manage is one aspect. How do we manage the pain and how do we understand the pain? How do we deal with the mobility issues? And how do we sustain our treatment and keep the owner interested enough to keep on the journey with us without going for alternative therapies or whatever? Well, we've got to try and learn to look at arthritis in a different way, because it really is incorrect to think about arthritis as a degenerative disease. A degenerative disease is something like multiple sclerosis, which when it starts, there's a very predictable pathway. What arthritis is a failed healing process. The joint is trying to heal, it just can't heal. And it's a stop-start disease. Quite often the joint will become dormant for periods of time and show no progression at all. But the key thing about this is if we try to think about arthritis in a different way, as understanding the activity in the joint, the attempt to try and heal, and also to understand that although there's no cure, there can be a compromise made which makes the joint pain-free and functional. So one of the big problems we have is attitude, because we don't really believe ourselves that we can make a huge difference with this disease. So we don't put a lot of effort into trying to do this. So attitude is a big problem. Secondly, belief that the joint, with a little bit of help, can improve is also important. And we often can get joints which are perfectly functional even though they've got established osteoarthritis. And the owner needs to know that as well. When we look at pain, we've got to understand pain. And we can understand pain as a protective mechanism, but in a chronic disease like osteoarthritis, the main problem that we have in the long term is dealing with chronic pain, which is very different from acute pain. And also, if you've got a constant stimulus to a nociceptive system, that system becomes sensitized, and it becomes much better at perceiving the pain, whereas what we would like is the opposite. So this is kind of the standard picture of an event in the joint producing pain, which produces a response which protects the animal. That's acute pain, makes sense, we all understand that. However, in chronic pain, something else happens. So we've got the response, which is there all of the time. So the joint becomes much more sensitive. And we actually can see this histopathologically. There are a lot of new pain sensors appear in the synovial membrane. So this becomes much more sensitive. And as a result, we get many more stimuli going up the peripheral nerve, which then makes the central system much more sensitive. So this is peripheral sensitization, this is central sensitization. And for the same stimulus, we get a much bigger response perceived in the brain. The problem's in the joint, the pain is in the brain. Now that's significant because suddenly, even normal activity becomes painful. So that's not a good situation. We've got to understand how to cope with that. The next stage is trying to understand chronic pain. And these are things where if you talk to people with osteoarthritis, they'll describe their pain in different ways. In fact, a recent study showed that people don't like to describe their pain in osteoarthritis. It's very difficult to get people to talk about it. And there have been 7 different pain dimensions, chronic pain dimensions, identified in human osteoarthritis sufferers. So it's not an easy thing to identify. So in humans, people will describe this as a burning, throbbing pain. It can be a sharp pain at times, but it's a constant pain. But it's hard for them to describe it. And one of the consequences of it may be behavioral, depression, and a feeling of hopelessness, which is not the person who limps into the room. And if we think about how this might manifest itself in our dogs, how do we identify that a dog is suffering from chronic pain? Well, I say it's not going to be the limping dog. It's going to be manifest as a behavioral change, which may be inactivity, reluctance to exercise. It could be aggression. Due to this feeling of insecurity. And these are not things that we logically associate with arthritis. So we've got to be much more careful about trying to judge how an animal is affected by this disease, especially in the chronic phase. And dogs, it's not really in the dog's interest to show you it's got a chronic pain problem. It's a pack animal. And so these animals are programmed not to show weakness. So it's going to conceal the chronic pain, which means our clinical examination has got to be much better at actually picking up these problems when we're trying to assess how good our interventions are. The other important thing, another reason why our focus is wrong in osteoarthritis often, is this concept that osteoarthritis is cartilage disease. And so we target the cartilage. And I love cartilage. It's a great tissue. But it's not the only thing that's affected in osteoarthritis. And I guess the new perspective is that osteoarthritis is a disease of an organ rather than a tissue. And so we take a much more global perspective on how we manage the disease. And this is a very complicated slide. Now, I'm afraid I've got some complicated slides, but this kind of shows the changing nature of osteoarthritis as the pathology develops. It starts off within the joint as a cartilage disease often. But as time goes on, more and more tissues in the joint and outside the joint become involved in the disease process, which just complicates the signs and complicates the treatment. So eventually, in the later stages, what we're getting is problems with mobility because of fibrosis, because of muscle problems, because of an extending pain situation involving multiple tissues. So we've got to address that and understand which part of the cycle our arthritic joint is on, because that's going to inform us what things are going to work better. In the early stages, we can target cartilage. In the later stages, we've got to just keep the joint mobile. Completely different approach. So, moving on, why is a multimodal approach more appropriate in dealing with this complex disease? And that's it, because it is a complex disease. And a complex disease often isn't resolved by a single intervention. And it's a lifestyle disease. So a lot of the lifestyle things will actually have an impact on the outcome. Sorry, I thought my watch had stopped, but this is one of the problems here. With osteoarthritis, we've got a lot of different things to choose from when we come to treat. In fact, from a bad perspective, we've got too many choices, and we struggle trying to think which thing will be best. From a good perspective, it's good to know that a lot of these things will work. A lot of them won't work. So why would we use something which we're not sure whether it works or not, when we've got a lot of choices which we can be much more secure with? And multimodal management is trying to select a combination of things that will work and use them together. So what we're trying to do is we're trying to use multiple treatments at the same time to give a better result than a single treatment. At the same time, that reduces the absolute dependence on that single treatment. And also, as we'll see in a second, it also may reduce the dose of a medical agent, which may be a toxic problem. And it also addresses the time situation, because a lot of these interventions take different times to come into play. So if an animal's in pain, you want an analgesic that works now. If I had an arthritic joint which was in a lot of pain, and I went to see the doctor, and I say, I'm in pain, I want something to take the pain away now. I don't want it to take the pain away in 4 weeks' time. I don't want to be in pain for 4 weeks until it takes the pain away. I want the pain removed now. But we've got agents we know that will do that, and we've got agents that will take 4 weeks to have an impact. By combining them, we can actually get both effects. When we've got so many different things to choose from, we've got to then focus on our targets for treatment. What are we trying to achieve? Well, we're trying to achieve pain relief, we're trying to improve mobility, and we're trying to return this animal to as near normal as possible. So we want an exercising, happy dog with a good quality of life. That's what our owners want to hear. That's what we've got to believe that we can actually achieve with our treatment. And the other factors, because it's a lifestyle disease that will impact on this, are things like the chronic nature of the disease, how damaged the joint is, the body weight and diet, the environment, the lifestyle of the owners, and the other owner factors themselves. So there's a whole range of different things that we've got to take into account to try and solve this problem. And my solution to this was a system I kind of made up a number of years ago, and I tried to use, and other people might have different solutions. What I'm just going to explain is how I try to address this problem, because it's easy to say, yeah, let's use a multimodal system. It's much harder to try and put that into effect. So this was just an attempt to try and make an illogical disease logical. So the first thing to do is to try and think of different areas that we want to intervene in, so different domains. And the ones I selected, and I did it in a kind of alphabetical thing, was pain management, analgesia, body weight and diet, care, which I'll explain later, disease modification and mobility, exercise and well-being. So there's 5 different areas that I was going to try and make an intervention in. Some of these would be more important than others at the beginning. Some of these would become more important as we get into more management of the disease at a later stage. But this was the essential plan, to try and intervene in these 5 areas. So if we look at pain management, the A box, if you like, and look at our choices, well, we've got a lot of choices. And one of the big challenges is to decide when to select what. Because I feel that people overcomplicate this by accelerating and using more and more agents rather than waiting for an effect and having patience. Now, without doubt, the most effective and most useful way to try and counteract a painful joint is using a non-steroidal. We've got lots of very good non-steroidal drugs which we can choose from. So that's kind of often the first attempt. If we feel we're not getting a good response, we can change to another non-steroidal, because response is an individual thing. And if an animal doesn't respond to one non-steroidal, it doesn't mean it's going to not respond to any non-steroidal. The next stage is to add something to the non-steroidal, to use in combination. So we go into a multimodal analgesic plan, where we use another analgesic which will complement the use of the non-steroidal. Going down again, if we think we've got a problem with sensitization, we can use drugs which are particularly appropriate in that situation because they interfere with the pain pathway at a level which counteracts sensitization. But we've got to kind of think that sensitization is there before we select one of these drugs. I find people start using these things too early and use them in isolation rather than in combination, where they're much poorer at having their effect. And of course, there are other things that we can use as well in trying to achieve our first aim, which is pain control. So that's the A box, pain control. Now, in my system, what I do is I actually divide the disease from the pain. And the reason for this is there are other interventions we can make at the level of the joint. Now, some of these are analgesic, but many of them actually have a later effect. If you've got two different targets, if pain's a target, you should use an analgesic, and then you can think about what other things can help looking at the pathology within the joint itself. So again, there are medical agents, but this is where things that act at the level of the joint become more important, like the intra-articular injections, like regenerative medicine, where we can use platelets or stem cells in the joint itself. But we're actually trying to alter the pathology. And as a result of that, try to achieve pain control. But we should actually try and do both at the same time. And there may be two different ways to do that, rather than trying to have a single intervention. One of the key points in trying to decide what we're trying to treat is to stage the arthritis, to try and identify what pathological state the joint is in. And that can go from the very early stage, where we think we know that a joint is going to become arthritic, to the end stage, where the joint is non-functional. And this is a little arbitrary, but it's supposing that a joint in this stage will respond to different treatments and interventions than a joint in this stage. It's completely logical, but we never do it. I mean, a good example of how an end-stage joint can be identified and managed is by a joint replacement procedure. But we wouldn't, as soon as we see an arthritic joint, go straight for a joint replacement. So we really need to have a look at the objective and then match agents to the problem. So it's a much more informed management choice, and it's just a way to try and sift out all these choices we have and try to think which things are much more likely to work in a particular situation. For instance, I believe logically that the regenerative procedures like stem cells are probably going to be much better to use in an early arthritis than in a joint which is becoming end stage. And likewise, in an end stage joint, we're probably going to have to use a lot more physical interventions to try and keep the joint mobilized, as well as using analgesics to keep it pain-free. It's a different approach. And multimodal, we can combine interventions in both areas at the same time to achieve a better result. Now, so that's pain management in the A box and the D box. There are other areas that we can actually intervene. Weight reduction or control, modification of nutrition, environment, using physiotherapy, which is becoming much more popular now, but often it's being used as a panacea rather than for a specific purpose. Exercise programs and social enrichment programs. So there's all these different things that address the global nature of the disease, and the letters beside there are the box that they fit into in the multimodal system. And I'll just try and expand that for you now. So these relate to these A, B, C, D, E, and F. And at the end, I'll show you how to construct a plan. So I just want to talk through some of these other things. So this is box B, which is the impact of nutrition in OA. And this is one of the things where we do have a lot of information about. And we've got two things that we consider here. One is obesity, and the other is these other supplements that we can use and are used really quite a lot to manage osteoarthritis. Obesity, we know that in man, if we can reduce body weight by 5%, it has a significant improvement in the clinical signs. And a reduction of 10%, only 10%, may be more beneficial than medication. And yet a lot of the dogs that we see with arthritis, which are overweight or obese, we actually don't target obesity as a primary intervention. And that's a mistake. In dogs, it's almost exactly the same. So in a study we did, we found that a reduction of 8% body weight in an obese dog gave a significant change in its outcome. So, and it was almost equivalent, again, to using a non-steroidal. So this is a really important thing. Now, you've heard about this study as well. I'm not going to say this is the opposite. This is actually dietary restriction throughout life as a preventative measure. And Penny talked about this study, which was an amazing study, but one of the things that it showed was that the dogs that had nutritional restriction were less frequently developed osteoarthritis, and the osteoarthritis that they developed was less in extent than their ad lib-fed compatriots. Thinking about supplements, the most exciting supplement, because it's the one that there's evidence that it actually does something, is EPA. And adding EPA to the diet displaces arachidonic acid and changes the whole inflammatory cascade and makes, or in theory, makes it easier to control any nociceptive pain. And I think that's kind of the main action. See, there's evidence that this works, and this is an unpublished study which showed that in a group of animals, the study group achieved an improvement with EPA alone, which again was equivalent in terms to using a non-steroidal. One of the problems with EPA in the diet is that a dog needs it's a big supplement that it needs, and it doesn't really work for 4 weeks. So it's going to be 4 weeks before you see any change at all. But it's a very exciting thing because it's a very positive way to try and augment the analgesics we use and perhaps make it easier for the joints to cope with the inflammatory situation they're in. The nutraceuticals are probably the most used medical agent in arthritis. These are the arthritis drugs. And I'm not going to give you a big opinion on these. I think that it's amazing to see how much expense and effort is used in giving this treatment to dogs when it's something we don't really know works. And in studies where people have tried to look at evidence for these things having a positive effect in osteoarthritis, there is very little evidence that that's the case. And yet they become a big component of many arthritis plans. I think choice is yours. It's just being aware that they aren't arthritis drugs. And if they're doing something, we still don't know what they're doing, which is important. So they shouldn't, in my opinion, is people can use them if they like, but don't use them as a primary analgesic, because they're not. If an animal's in pain, it needs an analgesic. Exercise, we all know that there are times where we want to restrict exercise, we want to encourage exercise. But how do we control that? Because we know that too much exercise in certain situations will damage the joint further. So how can we get the owners to comply with what we want them to do without spending the whole consultation talking about exercise? This is an exercise chart, and it doesn't really matter what this says. All this is, and again, it's arbitrary, these are 10 different levels of exercise described on a scale of 0 to 10. And the whole point is that it changes from no exercise to full exercise in 10 levels. And rather than explaining this to an owner, you can give them this chart and say, this is the exercise level here. I want you to use exercise level 5. If you read that and follow that instruction, that's what I want you to do. And when you come back in, we'll move you on to exercise level 4 or 6. And it just gives you control over that exercise. And more importantly, it gives the owner control because they know what they're supposed to be doing. Care is a strange one because there are certain things in this global approach we have to do. One is a lot of the drugs we use, non-steroidals, can be toxic. A lot of the animals we're treating may be geriatric and susceptible to that toxicity. So there's an art in using this, but care is trying to define the problem before you address it. To look at the susceptibility to make sure there aren't any factors there that will make it more likely for toxicity to occur. And also the other thing, a lot of animals used to come to me for hip replacements because they couldn't get into the car. Everything else was fine, you just couldn't get into the car. And if you were a 50-kilo Rottweiler, that was a problem for the owner because they would have had to lift them into the car. But in a lot of these dogs, apart from anything else, buying a ramp was much cheaper than getting a hip replacement. So we've got to be aware of toxicity, and we've got to be aware that the environment is important just on a day-to-day basis for an animal to cope. And doing simple things like providing a ramp just improves the animal's problem and improves the owner's situation. This again just shows the concept of multimodal and shows the limitations of individual interventions. And what we're trying to achieve here in a way is that if we can say, if we try to treat acute pain, we're going to get a rapid response and probably 60% improvement. As we look at these other interventions, again, there are different types of improvement, but as we put them together, we're hoping to get a synergistic effect, an additive effect at different time levels. So that's what we're trying to achieve when we're trying to put this jigsaw together. Okay, so this is all fine and well. How can you use it in practice? I'm just going to show you some case examples to finish off, just to show, I'm scratching the surface, how this can be employed. So this is a a dog here, a 3-year-old German Shepherd dog with a right hind limb lameness of short duration. There was a history of a longer problem of stiffness, even though it was such a young dog. And the owner was very aware that when the dog moved, they could hear something like scraping. Okay? So that's the dog's problem. But despite this, the dog was willing to exercise and fully exercise with the 2 other dogs that they had. So the owner brought the dog because they were really worried about this scraping noise, which they located to the hips. And occasionally had to be lifted into the car, so it's got a hip-type history. So the clinical examination confirmed that the hips were painful, and there was horrible crepitus from both hips, which confirmed what the owner was actually feeling and hearing. So osteoarthritis was the clinical diagnosis. Radiographs were used to confirm that, and the disease was graded at a 3, and the body condition score of this animal was 7 out of 10. So it was a bit of a fatty. These are the hips, which look awful. Yep, but this dog was running with these 2 other dogs normally. The only problem the owner could find was occasionally they had to lift the dog into the car and the crepitus. So this is just another example of a mismatch, because if I showed you these x-rays first, you would have said this dog can't walk. But it could walk, and it couldn't see its own x-rays. Here's the plan, A, B, C, D, E, and F. So we're going to focus on 2 things here. We're going to identify if the animal's in pain. So we need to break that cycle, so that's A. And we're going to stop the activity of the animal until we get this under control. So these are the priorities. This is the plan. So the animal's going to go into a non-steroidal straight away. And at the same time, we're going to reduce its exercise. Exercise level 9, 10 is nothing, 9 is very little, until we see what impact the non-steroidal has. We want to see this dog within 7 days, because I always like to follow up these dogs to make sure there's not going to be a problem with the non-steroidal. The other things we're going to look at is, because the dog is fat, we're going to change its diet now on day 1. It's going to be put on a diet to lose weight. We're going to give the owner some instruction so that they can spot if there's going to be a toxicity problem with a non-steroidal, which may happen, very low incidence, but we've always got to say that. And we're going to do nothing about the disease in this dog at this point in time. When it comes in 7 days, we review things, it's responding, there are no toxic issues, so we can carry on with the non-steroidal. There's no problems here. On the care side, we've actually discussed a ramp here. Now, we can start thinking about the disease, and we want to try and mobilize these hips, because there is a restriction there to see how far we can actually get them moving, because we've got the pain more under control, and we can start increasing the exercise level as well. And see the animal again in 28 days. But this time, hopefully, the weight is starting to come down, so we're starting to get another beneficial effect of that. But the key thing is that this is a record, and we can actually see what interventions we're doing, and we're increasing the exercise here as well, so we're getting some measurements as well. So we can track the progress for ourselves and for the owner. And in dealing with chronic disease, once we get this acute spike down, it's actually small gains are big victories. So we've got to be able to see them. Another example, this is a younger dog, 11-month-old dog, which has got bilateral elbow OA subsequent to osteochondrosis or elbow dysplasia. It's had an intervention. but it's still got a problem. And in this case, it's got very low-grade pathology, grade 2. The same kind of focus here, where we're looking at this case. Again, we're going to use analgesia to try and control the pain. The body weight's normal, but we're going to consider, so we don't need to diet this dog, we just need to control its nutrition. But in this dog, we may want to introduce omega-3 to try and help the analgesic effect of the non-steroidal. It's going to take 4 weeks for that to kick in. Again, we're going to talk to the people about toxicity. And we're going to, because this is an early stage, we're going to start thinking about maybe a more aggressive intervention to try and protect this joint, to try and sustain its function for a longer period of time. We're going to give it an exercise indication. I'm going to see the dog fairly quickly. So after 7 days, we're getting a response. We've started our omega-3, and now we're going to talk to the owners about regenerative medicine, either platelets or stem cells, because we've started to control the thing, and we're starting to plan now for the future. And that's the difference, because we're moving the plan on to deal with the rest of the animal's life, rather than just control the first problem. Last example is just to consider the problem in the geriatric dog. There are different things that we've got to deal with here. They tend to have a slower metabolism. They're much more likely to have another disease process going on. They are more likely to be on other drugs, so we've got to be aware of interactions. They're most likely to have OA, unfortunately, because they're older dogs, and they need pain medication, they need analgesia. Quite often we avoid these animals. We don't treat them because of the risks. We've got to treat them. So again, these are just some considerations here. In the analgesic box, we may think about using the coxibs, which are less likely to produce toxicity in theory. We may use a reduced dose, a subtherapeutic dose, to take account of the slower metabolism to try and stop accumulation. We may use acupuncture along with a non-steroidal or other adjunctives. Body weight is really important. If we can keep the body weight under control, it's going to be easier to do everything else. Care is going to be important because we've got to be vigilant for any side effects, any problems of the other diseases. The disease itself is gone. The joint's probably end stage, so we're just trying to keep the joint mobile. So we're not using regenerative therapies. We're not trying to save cartilage. We're just trying to keep a pain-free mobile joint. So it's a completely different focus often. And we're trying to improve the well-being by just allowing this animal to exercise as a normal dog. So again, it's just a slightly different focus, matching the situation. So just to conclude and summarize, I've tried to give you an overview of an approach which tries to take into account the complexity of the disease. It's a much broader approach than looking for the silver bullet. It's disease-specific. It tries to address the type of disease that we're treating so that we can actually get more appropriate choice of treatments themselves. It takes into account the patient and the owner circumstances. We're looking for synergism by combining interventions at the same time to get better effect. It's flexible because if we don't get the effect we want, we can very easily change, but we're using agents that we know will work in combination rather than struggling for things that maybe won't work. And it does provide a lifestyle plan for the whole course of the disease throughout the animal's life. And the main thing is, when treating arthritis, this seems to be complicated, but it's actually simplifying the process because you're using simple things in combination. And that's much more reliable to get results. So simplification is the key thing here, and using the appropriate thing in the right place at the right time. So thanks very much. I'm happy to answer any questions. I think I'm on time.